As internists, it is extremely likely that we will either encounter patients on buprenorphine or interested in starting it. So in this video, I want to do a quick review of medication-assisted treatment, as well as how to initiate buprenorphine. Methadone is a full agonist at the mu-opioid receptor, whereas buprenorphine is a partial agonist, and naltrexone is an antagonist. In general, the agonists are favored in moderate to severe opioid use disorder. And this is because there is a lot of robust data that shows that they decrease mortality by a very significant amount. I saw the relative risk of mortality, all-cause mortality, was something like 0.47 on a cohort of 550,000 patients. They prevent withdrawal, and they reduce cravings without causing the patients to become high or sleepy. And the reason that they do this is because they're both very long-acting. So as opposed to kind of illicit or short-acting opioids, these long-acting ones kind of get you that suppression of the withdrawal symptoms and the cravings, but none of that, high and addictive properties, which really helps to avoid the negative impacts on daily functioning and daily living that typical opioids have on patients' lives. Naltrexone is a very good option, but the problem with starting this is that you're going to need 7 to 10 days of abstinence before you can consider starting this, which can be very, very difficult for patients who have severe or moderate opioid use disorder. And then between methadone and buprenorphine, buprenorphine tends to be more favored as well, mainly because it has a better side effect profile. So in this case, it is a partial agonist, which means when it binds to the mu-opioid receptor, it's not fully activating it. And so in that sense, it kind of has a ceiling effect after about 24 to 32 milligrams. And overall, the risk of overdose or the risk of respiratory depression is significantly lower compared to methadone. You do still have to counsel patients to avoid alcohol and benzodiazepines, however, because there were some buprenorphine-related deaths that did occur in the setting of using alcohol and benzos. And also another benefit of buprenorphine is that it has less drug-drug interactions compared to methadone. And also, patients don't need to be going daily to a clinic to obtain this, so it has increased accessibility. And then there are multiple forms of buprenorphine. So you can have tablet form, you can have sublingual film form, and this is probably the most popular one because we have one called Suboxone, which is a combination of buprenorphine plus naloxone. So a lot of times you'll get the question, hey, this person's on Suboxone, isn't the naloxone going to cancel out any opioids that they're going to be getting? But the answer is that the naloxone is not really absorbed well PO. And so if the patient is taking it as prescribed sublingually, they're not going to get that naloxone component, which is like a full antagonist. But the reason that the naloxone is included is that if a patient was to try and divert this medication to the streets, for example, and then they wanted to liquefy it and then turn it into like an injectable form and then inject it to get a high, the naloxone would be present and actually fully disable any effects of that. So basically they wouldn't be able to inject it because of the naloxone that's present. You also have some longer acting forms. So for example, a Butrans patch is one form of buprenorphine. And then you also have long-acting injectable medications, so injectable such as Sublocade. Okay, but the biggest thing that you need to know for starting buprenorphine is that there is a risk of precipitated withdrawal. This is because the partial agonist, while it has all the benefits of that ceiling effect and decreased risk of respiratory depression, the problem is it actually has a very, very high affinity for the mu-opioid receptor. So when it binds there, it's actually going to kick off any active opioids or full agonists that are currently present. So if a patient has been recently on opioids or taking opioids, you're kind of going to be putting them into withdrawal by starting buprenorphine too quickly. So to mitigate this, we have two kind of ways to initiate buprenorphine. You have the traditional start and you have the microdosing start. And there are a ton of different protocols for how to do this. But in general, for what you do for the traditional start is you let the patient take their opioid and then you wait about 6 to 12 hours until they're starting to have withdrawal. So until having withdrawal. Once you've waited that period, you're going to assess how severe the withdrawal is by calculating a COWS score, which is a clinical opioid withdrawal scale. And then if that is greater than 12, then you are going to finally start buprenorphine. So you wait for them to get into a bit of withdrawal first, and then you give the buprenorphine, which will kind of relieve some of that withdrawal. So then you'll give, for example, you'll give their Suboxone. Usually the recommended dosing is 2 to 4 milligrams, and then you reassess in an hour or two to see if they need more, and then you give an additional dose if needed. Now, there are some protocols in the emergency department. So ED does have this more aggressive protocol that they will just give 16 milligrams up front, because it's actually shown that it improves adherence to therapy and actually, is just as effective. So they have like this aggressive initiation. And I have a website that kind of gives you all of these different protocols, so you can see all the different dosing regimens that you can do. But this is the traditional start to buprenorphine. So I'm going to say ED does aggressive starts also like 16 milligrams. So if you go here, this is the SAMHSA website, the Substance Abuse and Mental Health Services Administration. And they kind of say, last opioid use 6 to 12 hours ago. The patient is in moderate withdrawal defined by COWS of greater than 12. Then give the first dose of Suboxone, 2 to 4 milligrams. If you've caused precipitated withdrawal, then just treat the symptoms and then attempt induction again 24 hours later. But if not, you can wait a few, 2 to 4 hours. And if they still have withdrawal symptoms, then give another 2 to 4 milligram dose. And if their withdrawal symptoms are gone, then you can just kind of prescribe them this dose for the future. So this is kind of their algorithm for initiating buprenorphine. If you go to this website, it's called the Bridge to Treatment website. They have a lot of induction protocols here. So you can just search START. And so you can see the buprenorphine emergency medicine quick start. You can see the in-hospital start and the buprenorphine self-start here as well. So if you look at the emergency department quick start, you wait for them to get into opioid withdrawal, and then you just give them a huge 16 milligram sublingual buprenorphine dose. So again, some very useful websites, I would say, are the SAMHSA website and the Bridge to Treatment websites, which can give you some really good protocols on how to start. There is one caveat with the traditional dosing. So let's say the patient is on fentanyl, or if they are on methadone. So these are some special scenarios, essentially, mainly because people who are using fentanyl are going to have a very, very high degree of opioid tolerance. And then methadone, again, if you look back up here, it's a long-acting medication. It takes a while for the methadone to actually come out of the system. So these patients, you're going to actually have to wait longer than 6 to 12 hours to start. Generally, you're going to have to wait at least 24 hours. Sometimes they can say up to 48 hours. So wait 24 to 48 hours before starting. Okay, but waiting such a long time could be pretty difficult for patients. And so this is where the microdosing kind of formula came into play. All right, so the microdosing is really for any patients who are on fentanyl, who are on methadone, or if they are on acute pain medications and they are transitioning to buprenorphine. So in that setting, we see that quite commonly in the hospital. After a surgical procedure, patients on like a PCA pump, or they're on just like high doses of opioids, and they want to get back onto their buprenorphine or something like that. So how can we safely do it without having to introduce a withdrawal period? We can do this microdosing. And so the microdosing has an advantage because you don't have to wait for withdrawal, and you don't necessarily cause withdrawal, because you're basically just doing a very, very slow cross taper. You're adding in the buprenorphine while you're slowly tapering down on the opioids. So the advantage is no withdrawal. So there's several different cross tapers that you can do. But again, this is in the Bridge to Treatment website, where you can look at the microdosing protocols. And so in this case, this is kind of what we use at my hospital, but you start them on a Butrans patch and continue their full opioid agonists. And then you add a second patch and then a third patch. Then you start slowly adding buprenorphine at that point, and then you stop the full opioid agonist on day 6. I'm going to take a look here on this Bridge to Treatment website, but you can see there's the 3-day sublingual cross taper start, 7-day sublingual cross taper starts, which are also all feasible ways to do microdosing as well. Okay, and then the last thing that's useful to note for the patients who are having withdrawal symptoms is that there is a lot of supportive medications that you can give. So for sweating, signs of sympathetic overdrive, you can consider clonidine. and we do 0.1 milligrams every 8 hours as needed. For muscle spasms, you can do baclofen, 5 to 10 milligrams every 8 hours as needed. Again, for the sympathetic overdrive of withdrawal, you can also do gabapentin. So you can start at 100 to 300 milligrams TID and up titrate as needed. For anxiety, you can give Atarax, so hydroxyzine, 25 milligrams TID as needed. If they're having pain, then you can just recommend Tylenol or ibuprofen. For sleep, trazodone can be a useful adjunctive medication for withdrawal symptoms, 25 to 100 milligrams QHS if needed. And then nausea, we have Zofran, of course. For abdominal cramping, we have dicyclomine. And then for diarrhea, you have loperamide or Imodium. So definitely all things to consider if a patient is having really severe withdrawal symptoms and you want to provide some kind of care while they are trying to get started on buprenorphine. And some last housekeeping. So some questions that come up very commonly. So what about in the perioperative setting? Should patients have their buprenorphine held? The answer is no. You should actually continue the buprenorphine in the perioperative setting. And then if somebody is on buprenorphine, can patients receive full opioids for additional pain control? For example, let's say after the surgery, they're having a lot of pain. Yes. So if you have a strong opioid agonist, it can still bind the receptor and still give adequate pain control on top of the patient's buprenorphine. So in most cases, really just try to avoid stopping somebody's buprenorphine when they're in the hospital, because then you're going to have to do this whole withdrawal period again. And the patient is also probably going to have worsening pain. The other thing for buprenorphine is that if there is acute pain, and you just want to manage it with the buprenorphine, you can increase it from the daily dosing to TID, and just kind of split the dose into TID, because the analgesic effect of both buprenorphine and methadone is only like 6 hours or so. So if you just take let's say they're on 24 milligrams and you split it to 8 milligrams TID, you're going to be giving them more adequate pain control all throughout. So that's another strategy in the hospital. So this is both for methadone and buprenorphine. All right, now let's talk about who would benefit from being on methadone then. So like buprenorphine, methadone is dosed daily. But the problem is it is a little bit harder for patients to do. I mentioned that there's increased accessibility with buprenorphine, but the methadone, they're going to have to go daily to a methadone clinic, also known as an OTP, so daily to a methadone clinic, or OTP, which is an opioid treatment program. And then after they've done this for a long time, eventually they can start getting take-home bottles or take-home pills, so they don't have to go every single day. So for a lot of patients, this is just a lot more difficult to do, and they're going to have to be a lot more strict with going to it. But actually, for some patients, this kind of structure and routine is actually helpful for them in their recovery period. And so patients who may benefit from methadone are people who, considering patients who would benefit from a structured routine with frequent intervention and interaction with substance abuse counselors and things like that. There are some people who would actually do better with this kind of program. So good for patients who would benefit from daily structured routine. There is this 72-hour rule for patients who present to the emergency department. So basically, if somebody is starting methadone in the emergency department can provide 3 days of methadone to allow them time to get set up with their methadone clinic in order to start getting their daily methadone from then on. So ED can give 3 days of methadone. And generally, starting dose is going to be 30 milligrams. And you really want to increase it quickly, because most people really start to see a benefit after 60 milligrams in terms of reduction of cravings. And usually, the doses will end up being somewhere between 60 and 120 milligrams. So usually what the methadone clinics do is they go up by 5 to 10 milligrams every 3 to 5 days or so, until they get to a suitable dose. When a patient is admitted to a hospital, so we're going to see this a lot as hospitalists, the key thing to do here is call their methadone clinic to confirm their dosing, because you need to make sure that the patient is getting their methadone while they're in the hospital. And if the methadone clinic is not available, then one of the things you should do is at least give them 30 milligrams if not available, and then hopefully the next day you're going to be able to call and confirm the dose. So for example, the patient comes in at like midnight and nobody's available to confirm the dose. You can give them 30 milligrams. That should be safe. And then in the morning, you're going to call and get the dose and give the patient their normal dose. Okay. The main thing with methadone, a very common side effect that most people are aware of is that it can cause prolonged QCC. So usually you're going to have to monitor. So you're going to monitor your EKGs to make sure you're not getting into a dangerous range here. Oh yeah, and then one good thing about methadone, actually, in the palliative care setting, methadone actually has a lot of good uses too. So methadone is very bioavailable. So it's about 85% bioavailable, and it's predominantly absorbed in the stomach. Which is really helpful for patients who have like malabsorptive disorders, or they've had a lot of surgeries in their gut, or they have obstruction or something that's preventing them from absorbing medications. The methadone can be a useful medication to try for pain instead, because it's absorbed so much and so quickly in the stomach. So if they have absorption issues further downstream, it's not as big of a problem. And then also, methadone does have some benefits for neuropathic pain. So methadone does help with neuropathic pain as well, which can be helpful. All right, and let's finish off with naltrexone. So again, I mentioned it's not as favored as the other medications, but it can be very helpful. So you have a PO option and you have an IM option known as Vivitrol. And then the PO option is just PO naltrexone, or some brands called it Revia. And the IM option is really nice because it's like a 28-day injection. It's long acting. And so if a patient takes any opioids during this period, it will completely block the euphoric effect of that. So if the patient tried to take some heroin or something, it's actually not going to do anything while the Vivitrol is working. So opioids during this period will block euphoria effect. There's no physiologic dependence, which is pretty nice, because the full agonist and the partial agonists still require the patient to have some dependence on these medications. They're going to go into withdrawal if they stop taking them. So no physiologic dependence, which is nice. And then also no withdrawal in case they want to stop taking it, or if they want to switch to something else. So no withdrawal if stopped. Those are the advantages of naltrexone. So definitely a good option as well. I hope this was a helpful review of medication-assisted treatment for opioid use disorder, looking at our three main options, and then taking a look at how we start buprenorphine, whether it's the traditional method or the microdosing method, and why we would choose one method over the other. This is definitely not in my wheelhouse. I'm not prescribing this stuff all the time, but internal medicine does have a subspecialty of addiction medicine. And of course, like I mentioned in the beginning of the video, we are going to be interacting with these patients probably more frequently as time goes on. So it's good to have at least a baseline understanding of what the main options are, what the different side effects of the medications are, and things we should be looking out for. If you have any other tips yourself, or any feedback or questions, please leave them down in the comments down below. I hope you guys enjoyed this video. I'll see you in the next one, and peace.